Welcome to Lecture Boss. My name is Dr. David Avarbock, and today we will discuss the pediatric tumors you must know for steps 1, 2, and 3, and the shelf exams. This is the first of two lectures on this topic. Today we will cover tumors of the CNS, eye, skin, blood, heart, endocrine system, and kidney. In the second lecture, we will cover tumors of the GI system, bone and soft tissues, ovaries and testes, and extragonadal germ cell tumors. We have one of my medical students today who is applying in pediatrics who will be answering my questions. Let's start with central nervous system tumors. These tumors can be found in the cerebral cortex, brainstem, or spinal cord. Many of these tumors are associated with genetic syndromes. What is the most common benign CNS tumor?
That is a pilocytic astrocytoma, a grade 1 astrocytoma, and it's most commonly found in children from 5 to 12 years old.
Correct. Where is the tumor most commonly found?
It's most commonly found in the cerebellum and can lead to symptoms such as lack of coordination and balance and increased intracranial pressure from obstructive hydrocephalus. It can also be found along optic pathways and cause visual disturbances.
Good. Pilocytic astrocytomas are more common in NF1, and the tumor is more likely to be found in optic pathways, and they're known as optic gliomas. Astrocytomas can also occur along the spine. What are some other characteristics of this tumor?
A pilocytic astrocytoma appears as a well-demarcated tumor on MRI. On histology, the astrocytes have Rosenthal fibers, which are eosinophilic corkscrew fibers. It is GFAP positive. The tumor must be surgically resected and it has a good prognosis.
That's correct. Let's discuss another benign CNS tumor, a craniopharyngioma. Tell me the characteristics of this tumor.
It originates from Rathke's pouch, which is derived from surface ectoderm and forms the anterior pituitary. A craniopharyngioma is the most common pediatric suprasellar tumor and is located around the pituitary gland.
Very good. What are the signs and symptoms of a craniopharyngioma?
The patient will have clinical features of hypopituitarism, such as primary amenorrhea and central diabetes insipidus. The tumor can affect the transport of dopamine from the hypothalamus to the pituitary and lead to high prolactin levels. The tumor can also compress the optic chiasm and cause bitemporal hemianopia. It could also cause an obstructive hydrocephalus.
Correct. What are the diagnostic tests to help confirm a craniopharyngioma?
CT or MRI will show calcifications, and a biopsy will show cholesterol crystals in a fluid resembling motor oil.
Good. The tumor must be surgically resected, and it has a good prognosis. What is the most common malignant CNS tumor?
A medulloblastoma, which is derived from primitive neuroectodermal tissue.
That's correct. Where is a medulloblastoma most commonly found? And what are the signs and symptoms?
The tumor is most commonly found in the cerebellum, usually in the vermis, and it can compress the fourth ventricle and cause a non-communicating hydrocephalus and increased intracranial pressure. It can also lead to ataxia.
That's correct. The tumor is also capable of drop metastasis to the spinal cord, and it can cause compressive symptoms. A medulloblastoma can be associated with a syndrome that includes familial adenomatous polyposis, FAP. Which syndrome is this?
This is Charcot syndrome. FAP can also be associated with osteomas, which are benign bone tumors often found in the facial bones, and skin and soft tissue tumors. We call this Gardner syndrome.
Very good. Medulloblastomas can also be found in children with Li-Fraumeni syndrome due to inherited p53 mutations. What are the diagnostic tests for a medulloblastoma?
The tumor is best visualized on MRI. You will see a tumor in the cerebellum growing into the fourth ventricle. The spinal cord should also be imaged for metastasis. Biopsy will show home or right rosettes.
Correct. The tumor must be surgically resected. It has a 60 to 80% survival rate, and the prognosis is worse if there is drop metastasis. Let's discuss another malignant CNS tumor, an ependymoma. What are the characteristics of this tumor?
The tumor arises from ependymal cells, most commonly in the fourth ventricle. These cells make CSF.
Good. What are the signs and symptoms of an ependymoma?
Its location in the fourth ventricle causes a non-communicating hydrocephalus and increased intracranial pressure.
That's correct. What do we see on imaging and biopsy of an ependymoma?
An MRI will show calcifications, cystic changes, necrosis, and hemorrhage. Biopsy shows perivascular pseudorosettes.
Very good. Ependymomas have a poor prognosis. The tumor can also appear along the spine and may be associated with NF2, which may also have vestibular schwannomas and meningiomas. Let's discuss pineal gland tumors. There are many types, and the most common are extragonadal germ cell tumors. Pineal gland tumors can be benign or malignant. What are the clinical features?
Most of the symptoms of pineal tumors are the result of compression of the dorsal midbrain and a non-communicating hydrocephalus. These include headache, vertical gaze palsy, or Paranod syndrome, and precocious puberty from high HCG due to disruption of the hypothalamic regulatory pathways.
That's correct. These tumors have a high cure rate in part because they are very responsive to radiation therapy. We mentioned that brain tumors are associated with many syndromes, including Li-Fraumeni syndrome, the neurocutaneous syndromes, NF1 and NF2, and Turcot syndrome. What are other syndromes associated with brain tumors?
The other two neurocutaneous disorders also have brain tumors. Tuberous sclerosis has hamartomas and giant cell astrocytomas, and patients often have seizures. Von Hippel-Lindau disease has cerebellar hemangioblastomas, which lead to ataxia.
Very good. What CNS tumors can develop in MEN1, multiple endocrine neoplasia 1, as a result of a mutation in the menin tumor suppressor gene?
Patients can develop pituitary adenomas, such as prolactinoma, and experience symptoms such as galactorrhea, amenorrhea, and bitemporal hemianopia. Other pituitary adenomas in pediatrics include somatotropinomas, which secrete growth hormone, and corticotropinomas, which secrete ACTH and can cause Cushing syndrome.
That's correct. Let's discuss tumors of the eye. What are the characteristics of a retinoblastoma, the most common primary eye cancer in pediatrics?
A retinoblastoma is a tumor of immature retinal cells. It is caused by mutations in the RB tumor suppressor gene. The patient can inherit the gene in an autosomal dominant manner, and this increases the likelihood of tumors in both eyes. If the patient develops a sporadic RB gene mutation, the tumor will only be in one eye.
Very good. Inheriting the RB gene mutation also increases the risk of developing osteosarcoma. What are the clinical features of a retinoblastoma?
On physical exam, you will see leukocoria, a white fundal reflex instead of a red reflex. The patient may initially present with strabismus, which is misalignment of the eyes. The patient may have symptoms of glaucoma, such as painful red eye, and may have loss of vision as the tumor damages the macula.
That's correct. What is the treatment of a retinoblastoma?
If the eye is still salvageable, you can employ cryotherapy, retinal photocoagulation, radiation, or chemotherapy. If the eye is not salvageable, you will remove it along with the optic nerve so that the tumor doesn't spread along the optic nerve into the CNS.
Good. You will also surveil for osteosarcoma in these patients. The most common overall cancer of the eye will be metastasis from a leukemia, such as ALL. Let's discuss skin cancer. What are the genetic disorders that increase a child's risk of skin cancer?
Disorders where there is a defect in DNA repair increase skin cancer risk. These include xeroderma pigmentosum, which is caused by a defect in the excisional repair of pyrimidine dimers. Also, Bloom syndrome, caused by a defect in helicase. These children are at risk for all types of skin cancer.
Correct. Children with albinism, which can result from multiple gene defects, known as locus heterogeneity, are also at an increased risk of skin cancer. There is a disorder called nevoid basal cell carcinoma syndrome, or Gorlin syndrome, where children get basal cell carcinoma. Let's discuss cancers of blood cells in pediatrics. Leukemia is the most common type of cancer in children, in particular acute lymphoblastic leukemia, or ALL. What are characteristics of this tumor?
ALL is most commonly a cancer of immature B cells, called lymphoblasts, and less commonly T cells. The tumor arises in the bone marrow. Many tumors have a 1221 translocation, which creates a fusion protein, and this translocation can be detected using FISH or RT-PCR. This translocation has a favorable prognosis.
Very good. What are the signs and symptoms of ALL?
Fever, night sweats, weight loss, and painless lymphadenopathy. Patients may also have bone pain, anemia, thrombocytopenia from damage to the bone marrow. They may have more frequent infections because they lack functional lymphocytes and neutrophils. Patients may also have hepatosplenomegaly.
That's correct. If patients have T cell ALL, they are more likely to have a mediastinal mass causing SVC syndrome or airway obstruction. ALL can also metastasize to the CNS. Let's discuss diagnostic tests for ALL. What are the findings on blood smear and bone marrow biopsy?
Diagnosis of ALL requires greater than 20% lymphoblasts in the peripheral blood or bone marrow. There won't be hour rods in these tumor cells, as seen in AML.
Correct. What are the flow cytometry findings and immunohistochemistry in ALL?
Flow cytometry will be positive for CD10, a marker of immature B cells, and the B cell markers CD19 and 20. If the cancer is T cell origin, CD3 will be positive. Immunohistochemistry will be positive for TDT and negative for myeloperoxidase.
Good. What will cytogenetics show?
Cytogenetics using FISH will show the 1221 translocation.
Correct. We will also test for spread to the CNS using lumbar puncture, an analysis of the CSF, and possibly imaging of the brain and spine. What is the treatment of ALL?
Treatment will involve a combination of chemotherapeutic agents. One regimen includes using vincristine, asparaginase, and doxorubicin. Intrathecal drugs, such as methotrexate, will be used to prevent CNS spread.
Very good. What is an important treatment complication of ALL, and how do you manage this?
Patients treated for ALL can develop tumor lysis syndrome because of the tumor's rapid growth and sensitivity to chemotherapy. This can be prevented with adequate hydration and drugs that prevent the formation of uric acid, such as allopurinol. If tumor lysis syndrome develops, treat it with resburicase to remove the uric acid and correct electrolyte abnormalities of potassium, phosphate, and calcium.
Correct. Another complication of ALL is leukostasis. The high white blood cell counts can obstruct blood vessels, causing hypoxia and tissue necrosis. This is treated with cytoreduction, initially with hydroxyurea. Plasmapheresis can also be used. While ALL is the most common subtype of leukemia, acute myeloid leukemia, or AML, still represents 15% of cases, and the most prevalent subtypes of AML depend on the child's age. What are some characteristics of the tumors in AML?
AML involves malignancies of the myeloid line precursors. It's most commonly a cancer of immature myeloid cells called myeloblasts, which become granulocytes such as neutrophils. There are many subtypes of AML, and these have high numbers of different myeloid precursors.
Very good. What are the signs and symptoms of AML?
Fever, night sweats, weight loss, and painless lymphadenopathy. Patients may also have anemia, thrombocytopenia, and bone pain from the damage to the bone marrow. They may have frequent infections because they lack functional neutrophils. They may also have hepatosplenomegaly.
That's correct. Let's discuss diagnostic tests for AML. What do you see on blood smear and bone marrow biopsy?
Diagnosis of AML requires greater than 20% myeloblasts in peripheral blood or bone marrow. In some subtypes, such as acute promyelocytic leukemia, APL, there will be arrow rods, which are fused lysosomes.
Correct. What are the findings of immunohistochemistry in AML?
The tumor will be positive for myeloperoxidase and negative for TDT.
Good. What will cytogenetics show?
Cytogenetics using FISH will show the 1517 translocation in the APL subtype, which results in a defective retinoic acid receptor. There are translocations present in other subtypes.
Correct. What is the treatment of AML?
If the patient has an APL subtype, you treat it with all trans retinoic acid. Another common chemotherapy used in AML is cytarabine.
Good. What are complications of AML?
AML patients are at risk for tumor lysis syndrome. They also have a high risk of leukostasis. Another serious complication when tumor cells lyse is DIC, disseminated intravascular coagulation.
That's correct. Let's discuss lymphomas. What are the types of lymphoma in the pediatric population?
Children can get both Hodgkin and non-Hodgkin lymphoma. Hodgkin would be more common in older teens. The most common non-Hodgkin lymphoma is Burkitt lymphoma. Children can also get diffuse large B-cell lymphoma.
Very good. What are the characteristics of the tumor in Hodgkin lymphoma?
You will see Reed-Sternberg cells, which are B-cell lineage and are positive for CD15 and 30. These cells are negative for CD19 and 20, markers normally found on B cells.
Correct. What are the risk factors for Hodgkin lymphoma?
The most significant risk factor is Epstein-Barr virus infection. Other risk factors include immunosuppression from HIV and chronic immune stimulation from autoimmune diseases such as lupus and rheumatoid arthritis.
Good. How do you treat Hodgkin lymphoma?
The four-drug regimen includes doxorubicin, bleomycin, vinblastine, and dacarbazine.
Correct. Let's discuss non-Hodgkin lymphoma. What are the molecular features of Burkitt lymphoma, a high-grade lymphoma?
Burkitt involves an 814 translocation and upregulation of the c-Myc transcription factor.
Good. There are several forms of Burkitt. Name two of these.
The form that is most common in the United States is a sporadic form, and it presents as an abdominal or pelvic mass. Symptoms can include abdominal pain and distension, nausea, vomiting, and bleeding from obstruction. Endemic Burkitt is associated with Epstein-Barr virus and can be found in Africa. It presents with a mass in the maxillary or mandible bones.
That's correct. Non-Hodgkin lymphoma, and in particular Burkitt, is the most common malignant GI tumor in children and is most commonly found in the ileum. What are diagnostic tests for Burkitt lymphoma?
Genetic testing will show the 814 translocation. Lymph node biopsy and histology will show tingible body macrophages dispersed among neoplastic lymphocytes, a starry sky appearance.
Good. How do you treat Burkitt lymphoma?
Rituximab is used to target B cells, and it is combined with a chemotherapeutic agents in various regimens, such as cyclophosphamide, vincristine, doxorubicin, and methotrexate. Prednisone is also used because it limits B cell survival.
Correct. If a child develops a different high-grade non-Hodgkin lymphoma, such as diffuse large B cell, we often use the R-CHOP regimen, combining rituximab with cyclophosphamide, doxorubicin, vincristine, and prednisone. As in leukemias, intrathecal chemotherapy is often used to prevent CNS spread. Tumor lysis syndrome is also a complication because of the rapid growth of these high-grade tumors and sensitivity to chemotherapy. Other cancers of blood cells, such as multiple myeloma, polycythemia vera, and essential thrombocythemia, do occur in the pediatric population, but they are very rare. Let's discuss a tumor of the heart, a rhabdomyoma, which is a tumor of cardiac striated muscle. These are the most common primary cardiac tumors in infants and children. What disorder are they commonly found in, and what are the clinical features?
Rhabdomyomas are common in children who have tuberous sclerosis, a neurocutaneous disease. They are most commonly found in the left ventricle and interventricular septum. They can lead to symptoms such as mitral regurgitation, arrhythmias, and heart failure.
Correct. Let's discuss endocrine tumors. What are the thyroid cancers that can develop in children?
The most common thyroid cancer in children is papillary thyroid cancer, and these children often have a history of radiation exposure. Medullary thyroid cancer is also possible in children with RET pro-oncogene mutations, such as in MEN2 syndrome.
Good. Patients at high risk of medullary thyroid cancer require prophylactic removal of their thyroid. Follicular thyroid cancer can also rarely appear in children. MEN1 and MEN2A can be associated with another endocrine tumor. What tumor is this?
MEN1 and 2A can have a parathyroid adenoma. This is rare in children, usually after 10 years old, but it can present with more severe symptoms of hypercalcemia than in adults.
That's correct. Pancreatic tumors are rare in children. What is a syndrome that puts children at risk for these tumors?
Children with MEN1 syndrome caused by mutation in the menin tumor suppressor gene have an increased risk of pancreatic neuroendocrine tumors that secrete hormones. These islet cell tumors include insulinomas, gluconomas, gastronomas, VIPomas, and somatostatinomas, creating symptoms of hypoglycemia, hyperglycemia, peptic ulcers, or watery diarrhea, respectively.
Very good. Patients with von Hippel-Lindau disease also have a risk of pancreatic neuroendocrine tumors. Carcinoid tumors are neuroendocrine tumors, sometimes found in the pancreas, but more commonly in the appendix or small intestine. They are rarely found in children. What neuroendocrine tumor is found in the adrenal medulla or sympathetic ganglia? Describe characteristics of this tumor.
A neuroblastoma is a tumor of neuroblasts, neural stem cells that can differentiate into neurons or glial cells. It is most commonly found in children under 5 and is the most common solid organ tumor in infants and children under 5. It usually develops in the adrenal medulla, and the neuroblast can differentiate into chromaffin cells and secrete catecholamines, primarily epinephrine. These tumors have a loss of tumor suppressor genes, as well as overamplification of the NMYC proto-oncogene.
That's correct. What are the clinical features of a neuroblastoma?
Neuroblastomas most commonly present as non-tender, irregular abdominal masses that cross the midline. This is in contrast to the smooth, unilateral mass of a nephroblastoma. The patient may have abdominal pain from mass effect. If tumors are found in the paravertebral ganglia, they can cause spinal cord compression. If they are found in the neck, they can cause Horner syndrome as well as spinal cord compression. If they are found in the orbit of the eye, they can cause periorbital ecchymosis or raccoon eyes, similar to what you would see in a basilar skull fracture.
Very good. Other clinical features may be the result of paraneoplastic syndromes. Name some of these features.
The patient may have opsoclonus myoclonus, which is jerking movements of the eyes and the limbs. The tumor might secrete excessive catecholamines, causing hypertension, tachycardia, and sweating, similar to a pheochromocytoma. If the tumor secretes VIP, it will cause diarrhea and electrolyte disturbances.
Correct. What are some of the modalities used to diagnose a neuroblastoma?
You can measure catecholamine metabolites in the blood and the urine, such as HMA and VMA. You can also do an MIBG scan, a type of scintigraphy to localize the tumor. You can perform a biopsy of the tumor to look for NMYC amplification. Histology will show Homer-Wright rosettes, and the tumor markers include bombesin and neuron-specific enolase.
Very good. These tumors are treated surgically with chemotherapy. An MIBG radioactive tracer can also be used to treat the tumors. A pheochromocytoma is also a tumor of the adrenal medulla, but is less common in children than in adults. It will also have catecholamine breakdown products in the blood and urine. It can be associated with genetic disorders in children, such as MEN2, NF1, and von Hippel-Lindau disease. Let's discuss renal tumors. What is the most common malignancy of the kidney in children?
This is a nephroblastoma, or Wilms tumor. It occurs most commonly in children under 5 years old.
Correct. What are two syndromes associated with Wilms tumor?
Wilms tumor is associated with a Wagner syndrome, where the patient may have a missing iris or genitourinary malformations. These patients have mutations in the WT1 tumor suppressor gene. Wilms tumor is also associated with Beckwith-Wiedemann syndrome. These patients may have enlargement of half of their body, umbilical ring hernias, omphalocele, and hepatoblastoma, the most common pediatric liver tumor. These patients have mutations in the WT2 tumor suppressor gene, and this can be imprinted.
Very good. What are the clinical features of Wilms tumor?
The tumor presents as a non-tender, smooth, unilateral mass. This is in contrast to a neuroblastoma, which is irregular and crosses the midline. The patient may also have hematuria, hypertension, and abdominal pain from mass effect.
Correct. How do we treat Wilms tumor?
It is treated with a nephrectomy. It is also treated with chemotherapy. A common regimen is vincristine plus dactinomycin.
Good. Patients who have a syndrome associated with Wilms tumor should have regular screenings every 3 months with renal ultrasound until age 8. The second most common pediatric renal cancer is renal cell carcinoma. Though rare, it can be associated with two genetic syndromes. What are these syndromes?
Renal cell carcinoma can be associated with the neurocutaneous diseases von Hippel-Lindau and tuberous sclerosis. VHL involves mutations in the VHL tumor suppressor gene, which regulates hypoxia-inducible factors that increase blood vessel growth and RBC production in low oxygen conditions. Patients with VHL can also have pheochromocytoma, hemangioblastoma, and pancreatic neuroendocrine tumors. Tuberous sclerosis involves mutations in the TSC1 and TSC2, encoding hamartin and tuberin, respectively. These patients have multiple types of skin lesions, and as we mentioned earlier, brain and heart tumors.
Very good. There is a new drug that inhibits hypoxia-inducible factor called belzutifan, and it is used to treat the tumors associated with von Hippel-Lindau disease. Thank you for joining us for the first of our 2 lectures on pediatric oncology. We hope you learned a lot. Additional notes on this topic will be available at lectureboss.com or by following the link in the video. Take care.